Hi, everybody. Welcome to our presentation regarding navigating adverse outcomes. We're going to start off today talking a little bit about the law associated with adverse outcomes, the reporting requirements primarily, just as a little refresher. I know you guys live this all the time, but sometimes it's good to go through a little bit of the nuances of the various laws. So we're going to start off with the issues that become probably most contentious about reporting is when we have to report individual physicians. And we're going to talk about what reporting individual physicians or other types of practitioners looks like in the three states, New York, New Jersey, and Connecticut. And every state, I think, in the United States has some form of reporting obligation. We're just focusing on these three for right now, but other states are going to have similar issues. And when you evaluate whether you have to report an individual as a result of some adverse outcome, there's some preliminary questions you have to think about. First is, what state are you in, for those of you who are in multi-states? Two, what type of licensed professional is this? Usually the distinction is physician versus non-physician. Three, was there an adverse action that was taken, or was it just the fact that the licensed professional acted in some manner that might rise to the level of misconduct? So you'll see with the states, there are different laws depending on each of those scenarios. So starting out with New York, we have the Office of Professional Medical Conduct, OPMC, everybody's heard of it. You do have a reporting obligation to the OPMC about physicians and physicians' assistants. And there are kind of two different reporting laws, the Public Health Law 230 and 2803E. And roughly what they say is, first of all, if an Article 28 facility, so certainly a hospital or an ASC, takes an action that limits or restricts an individual's medical staff membership, clinical privileges, association with the entity, and it's based upon issues associated with conduct or competence related to patient safety or care, then you certainly have a reporting obligation to the OPMC. In addition, individual physicians have an obligation to report to the OPMC if they have reasonable knowledge, so that's the standard, reasonable knowledge, that another physician or physician assistant has engaged in misconduct. So those are the two reporting obligations in New York for physicians. Now, I'm not going to go through all the definitions of misconduct. They're found in the education law. It's a long list of about 50. If you are in this situation, you should look up whether or not a person has engaged in misconduct, but we're not going through that now. Then for non-physician or physician's assistants, reports go to the Office of Professional Discipline. And the law that requires reporting of non-physicians to the Office of Professional Discipline is the same law as for physicians, 2803E, and again requires that Article 28 facilities report if they take an action against any practitioner who engages in activities that are not competent or that reflects poorly on their competence or conduct related to patient care or safety. The thing that's unique about practitioners other than physicians is that other practitioners do not need to report practitioners to the OPD. It is only Article 28 facilities who take actions against practitioners that have to report. So it's a bit of a difference, but when you're analyzing a reporting obligation, but I think that is a very big one in New York. In comparison, in New Jersey, it is the same reporting requirement for all types of licensed professionals. So healthcare facilities in New Jersey have an obligation to report if they take an adverse action against a licensed healthcare professional based upon competence or conduct related to patient care, safety, treatment, type of thing. It's a little bit broader in New Jersey, what they think of as an adverse action. It includes things like taking leaves of absence, retrospective review, wherein those things in New York might not be reportable. So it's a little bit different in New Jersey, a little bit broader. If you guys remember, many years ago, there was Nurse Cullen, who was going from facility to facility in New Jersey and Pennsylvania, actually ending the lives of patients who were terminal. And that individual, when they were caught, resulted in what was the Cullen Act, and that is the reporting obligation in New Jersey. Similar to New York, healthcare professionals, all healthcare professionals that are licensed have an obligation to report other healthcare professionals that they believe have demonstrated impairment, gross incompetence, or unprofessional conduct. So once again, it is all healthcare facilities in New Jersey have to report all types of licensed healthcare professionals, and all types of licensed healthcare professionals have an obligation to report other licensed healthcare professionals.
Stacey, just one comment.
Mm-hmm.
Certainly in New York, and I believe the same in New Jersey, although individual physicians under the law have a responsibility and obligation to report suspected misconduct by a physician, they can discharge that obligation by bringing it to the attention of a chief medical officer or somebody in a similar position who would be in position to make the necessary report. And then they don't have to get involved or report anything on their own.
Right, that's an important point, Len. So it's not that both the facility and the doctors have to report. It's if the facility reports, the doctors have been considered to have reported. So yes, that's an important point. The OPMC and the Department of Consumer Affairs in New Jersey do not necessarily report 10 different people reporting about the same incident.
And one other thing on the OPMC reporting, although it is true that the report is required if an adverse action is taken against privileges, the report is also required if the individual resigns or relinquishes association or privileges to avoid disciplinary action, or if the individual's employment is terminated for reasons related to professional competence and conduct. So it's not just the medical staff privileges issue, it also, under the state laws, reaches employment, which is distinct from the data bank, which we will talk about later.
Right, another excellent point. Thank you. And then Connecticut is similar to New York and New Jersey. Both hospitals and other healthcare entities and healthcare professionals have an obligation to report other healthcare professionals who have impairment, excessive use of drugs, incompetent or negligent conduct, that type of thing listed here on this slide. However, in Connecticut, it's interesting that if you have a situation where an individual, you're reporting an individual for misuse of controlled substances or drugs or that type of thing, the reporting obligation is considered to be fulfilled if the individual is reported to an assistance program. That is not the same in New York and New Jersey. That is unique to Connecticut. In Connecticut, there are also some additional definitions of misconduct for physicians that are not the same for other licensed practitioners, and you see them here. For example, failing to adequately supervise a physician assistant in Connecticut is considered to be misconduct, or failing to get accreditation of certain radiology equipment. So they have a bit of a different definition for physicians. What is misconduct? It's broader than other licensed professionals in Connecticut, and a little bit broader than what we see in New Jersey and New York. Same goes for Connecticut. If you resign or resign privileges or medical staff membership or employment, there's, in order to avoid an investigation, there's also reporting obligations. Now we go on to the data bank, and Lynn's going to give us a little summary of the data bank reporting obligations. I want to note for all these licensing boards, what happens is the report goes to the licensing board investigates, and only if they take action against the individual's license is it really publicly available. It's a little bit different for the data bank, and so we wanted to be clearly making that distinction as Len goes through the NPDB reporting obligations.
So the National Practitioner Data Bank is a creation of a federal statute known as the Healthcare Quality Improvement Act, which came into effect nationwide in 1990. And the act was created and passed by Congress as a result of a particular incident that occurred in a state in the southern part of the middle or southeastern United States, where I believe it was an anesthesiologist had engaged in certain conduct that resulted in the death of a patient, and then resigned from privileges in employment and moved across the country to, I believe it was the state of Washington, got privileges at a hospital there, and the hospital granted privileges, and I think the group employed the anesthesiologist, and they were unaware of what had happened in the prior state with the anesthesiologist's conduct and the patient death. And there was a lot of litigation. It received nationwide attention, and as a result, these issues were brought to the attention of Congress. There was also another case in which a physician had sued a hospital and members of medical executive committee of medical staff who had imposed corrective action on the physician, and won an antitrust verdict of millions of dollars against the hospital and the physicians. These two events led to I think the American Medical Association and various other professional organizations going to Congress and saying, one, we have two issues to address. One, if physicians who engage in peer review are going to be held personally liable for this type of conduct, that will effectively be the end of peer review. And two, there has to be a way to stop physicians from going from state to state to continue engaging in conduct that does or might endanger patients. As a result, the Healthcare Quality Improvement Act was passed. That is an immunity statute that provides for immunity for good faith peer review. And it also creates a nationwide database, which is called the National Practitioner Data Bank. And the law requires that before a hospital or a healthcare facility that engages in formal peer review grants privileges to a physician to treat patients at the facility, they have to inquire of the data bank to see if any reports of adverse actions have been made. At the same time, the Healthcare Quality Improvement Act requires reporting to the data bank of adverse actions taken against physicians' privileges. And, what circumstances trigger a report and the various gray areas and definitions could be the subject of a 2 or 3 hour program. So we're not going to get into those details, but on the screen, as you'll see, there are two primary things to keep in mind. Any action that restricts, terminates, suspends, etc., physicians' privileges for more than 30 days and is based on professional competence or conduct that either adversely affects or could adversely affect the health or welfare of a patient has to be reported to the data bank. And also the acceptance of a surrender of privileges while the physician is under investigation relating to possible incompetence or improper professional conduct, or in return for not conducting an investigation or to avoid disciplinary action, that is also reportable to the data bank. Some additional considerations. So for example, if there is a recommendation that an adverse action be taken, whatever it might be, that would restrict the physician's privileges. That is not reportable until the governing body of the entity makes a final decision. So usually you go through a fair hearing process, and committee issues, a hearing committee will issue a report and recommendation. The governing body will act on that. Once that's finished, then the report is due. But in the case of a summary suspension, that has to be reported once it's been in effect for 30 days, even if the hearing hasn't yet occurred. And a question that comes up frequently is, well, when is the report due? And according to the data bank, it is technically due on the 31st day. What happens if you're a bit late? Nothing will happen if you're a bit late. The fact that you may have missed the reporting deadline doesn't excuse you from, excuse the facility from making the report. And the data bank is much more interested in reporting compliance than penalizing a facility for being a bit late in making the report. And as I mentioned before, the Healthcare Quality Improvement Act is an immunity statute. So it provides a list of various things that the practitioner should be provided in the hearing process. And if those things are provided, then immunity should attach to any actions taken.
Thanks, Len. Okay, so we have some scenarios to actually talk about the actual application of these things we're going through, but just a few other reporting considerations in addition to reporting individuals. Obviously, if we have controlled substances involved in any type of scenario, we have to consider whether there has been diversion, and diversion gets reported to to the DEA and sometimes to state narcotics boards. So definitely something to keep in mind. There are typically state incident reporting obligations. In New York, we have NIPORTs. New Jersey, the New Jersey Patient Safety Act. So if the situation or the adverse event rises to the level of those reporting obligations, reports would need to be made there. Obviously, if you have an incident or an event that involves misuse of patient information, you have to consider whether you have to make a report to the OCR. And for most states, to the state attorney generals. Connecticut has a pretty significant reporting obligation that extends beyond social security numbers and that type of thing that we typically think about reporting to state attorney generals. So certainly if you ever have a loss of personal information, you have to consider whether there needs to be a report to the state attorney generals. And then also the accreditation agencies have different reporting obligation for different types of events. I don't have access to all of your accreditation agency standards, but when you have an adverse event, it's time to wipe off those standards and evaluate whether it is something that needs to be reported to the accreditation agency. So with all those things in mind, all those reporting obligations in mind, we're going to flip to the scenarios now, and we can hear from our experts about how they would respond to some of these situations.
Stacey and Len, before you get into the scenarios, I just have one question that comes to mind. For the individual provider at an ASC and some of the scenarios you're going to be presenting, what is the exposure, or is there exposure for that individual physician if he makes the referral to the OPMC? Let's say the board of the ASC doesn't agree that this needs to be reported, but the individual physician feels strongly enough that there was misconduct here. Is there any protection similar to a whistleblower in this scenario? Will the physician who was being reported ever find out who reported him?
Well, the public health law provides protections on both of those issues. It does provide for immunity from liability for any report made in good faith. So any individual who reports suspicion or reasonable, it's not even suspicion, reasonably believes that a professional misconduct may have occurred. That's the language of the statute. And if that's reported and there's a good faith basis for it, they're immune from liability for making the report. Secondly, reports to OPMC are confidential and not subject to disclosure in civil lawsuits.
So there are similar laws that protect if you report to OPD as well in New York. And there are similar immunity protections in Connecticut and New Jersey for reporting as well. So typically, someone cannot bring a lawsuit against you for making an individual report if the facility does not deem. Now, I can protect people from not liking each other, like that kind of practical thing, but there should not be reports made as to who made the report, and there certainly would be defenses if there would be any type of lawsuit brought.
And while we're talking about immunity for reporting to OPMC, it's worth noting that there is a reporting immunity in the Healthcare Quality Improvement Act that provides for very, very strong protection for any entity or individual making a report to the data bank. So there are two types of immunity under the Healthcare Quality Improvement Act. Most people are in the healthcare industry are familiar with the first kind, which is that if you engage in good faith peer review, then you're immune from liability for professional review activities such as the investigation and professional review action, which would be whatever action is taken against the privileges. There's an entirely separate section in the statute that provides for immunity from liability for actually making the report. There's a very, very strong immunity there.
Thank God. We appreciate that immunity. Okay, so was it supposed to be the right or left? Dr. Smith is a high volume surgeon at Feel Better ASC in New York and also an owner. The medical director has noticed that in the last few months there has been an increase in the number of post-operative infections associated with Dr. Smith's cases, and at least one return to the OR for repair and intestinal perforation. The cases were all reviewed by the QAPI committee with no deviation from the standard of care noted. Nevertheless, the trend was concerning. Then, on a very high volume day, Dr. Smith performed the wrong procedure on a patient. But the mistake is only noted after the patient was in the recovery room. An immediate review of the record indicates that a timeout did not occur upon interview. And upon interview, the anesthesiologist, who according to this ASC's policy is responsible for initiating the timeout, reported that Dr. Smith had specifically instructed that no timeouts occur because the schedule was too tight. Dr. Smith alleged that it was the preoperative staff who brought in the wrong patient and not his fault. So, what, Dr. Brodsky, what should happen next? We operated on the wrong patient or the wrong procedure on the patient.
So the first thing is just a question, the QAPI committee said there was no deviation from the standard of care noted, except there was a timeout that did not occur. So in my mind, that would be, certainly when I review charts in our QAPI committee as medical director, that would be a major issue, that there wasn't a timeout. The surgeon did an initial, decided they were going to operate on. So that certainly, that should have occurred.
So how important is the timeout in these?
Oh, it's extremely important. Extremely important. I do understand at busy ASCs, it's a process that may slow things down. A few minutes from some busy physicians may irk them, but it's necessary. We have tweaked our timeout to be as efficient as possible. But it is a point that at a time before the procedure happens, that everyone identifies their role. We all have the patient identify themselves, what procedure they're having, and it's a last minute check, a pre-flight check to make sure there's no allergies that you didn't know, sleep apnea, anticoagulants, cardiac issues. So it's extremely important. And if in fact the timeout occurred for this case, then the wrong site operation would not have occurred. So that's extremely important.
Right. So now we have a patient who has had the wrong procedure performed on him. What do we say? Like, do we tell the family? Do we obviously have to tell the patient? Do we
Well,
offer
the patient,
to do the
patient and
procedure?
the family, in my mind, do have to be spoken to. You bring them to a quiet point of the ASC, and usually it would be the physician, usually the nursing director, and perhaps even the administrator, together get together, and they have to speak to the patient. You cannot sweep this under the carpet.
Right.
It's a difficult conversation to have, but it's a conversation that has to be done. And then the other thing is certainly after that conversation, that's when you would reach out to legal and to your malpractice carrier to report this. So you have as much protection as you can in an unfortunate situation.
Right. So Len, now we have this situation. We've talked to the family. We've probably done the right procedure if they're willing to let us do it and that type of thing. What does this investigation look like?
Well, I would say that probably all facility medical staff bylaws and risk management guidelines require that an investigation be conducted whenever you have a situation like this. And sometimes they will spell out who is responsible for conducting the investigation. Usually the medical director and or chief medical officer are involved, or their designees. Everybody who is involved in the procedure, the surgeon, the anesthesiologist, the technicians, or nurses, should be individually interviewed. Their statements should be documented in writing and be kept in a confidential file for safekeeping. And once that investigation is done, the results of it should be brought to the attention of whoever in the facility is responsible for overseeing the quality of care that's provided, to make a recommendation as to what should be done with respect to the individuals who are believed to be responsible for whatever the deviation is. In this particular case, you have at least two individuals. One would be the surgeon, and potentially, maybe at a lesser level, the anesthesiologist, who is responsible for ensuring that the timeout occur and not to be bullied by the surgeon. What that recommendation should be depends on numerous factors. So you would want to consider whether or not this is a first-time offense, whether or not it is a continuation of a pattern of behavior that's been demonstrated before, the extent of patient harm, the individual's willingness to accept accountability, and whether or not they show any insight into what the problem was. All of this will have an effect on what might be a prudent and appropriate recommendation to send the appropriate message and to hopefully prevent a recurrence of this type of incident. So the options are anything from a focused professional practice evaluation, which is commonly found in hospitals. In ASC, it might be called a corrective action plan or whatever, up to and including, depending upon the factors we just mentioned, corrective action, suspension, restriction, etc. And by the way, the FPPE/corrective action plan could have a variety of different components to it. Could be less restrictive, more restrictive, and depending upon what those components are, they may trigger reporting or may not.
What would be the time course that you would want your investigation to occur? So if this occurred on a Monday, and then the physician had a full schedule each day for the next of the week, would you advise the ASC to, because certainly I would say for practical matters, there's almost no way that you would be able to do, a thorough investigation by the next day.
Right. Well, our advice to clients is always premised on practical realities faced by the clients. There's no way you're going to get this entire investigation done and recommendations made in a day or two. So clearly the most prudent thing to do would be to have a meeting with the surgeon and the anesthesiologist and say, look, timeouts are important, they're required, and you must do them, period. We don't want to see this happen again. We're investigating, you'll both be interviewed, etc. But in the meanwhile, 100% adherence to this requirement is necessary. And
Dr.
that
Brodsky,
should be,
go
hopefully
ahead.
that would be sufficient to prevent further occurrence of whatever the issue was, in this case, a lack of a timeout, while you proceed with your investigation, which you would like to get done as promptly as possible, maybe within a week's time or so.
So Dr. Brodsky, let's say we finished our corrective action and we find that the physician was wrong, right? We'll just focus on the physician for now. And we think that there needs to be some type of corrective action. He's known for ignoring the rules, should have known his patient, all litany of things. Do we do a different corrective action just because he's an owner?
No, I don't think you do. This is something that I think majority of the ASCs are going to have owner physicians doing the cases with a few non-owners. It makes it, certainly more difficult for any conversation, not just for this conversation here, but for any conversation. But you can't. I mean, it's the standards of the owner has got to be if the person was a non-owner. It just makes the conversation on a personal level and a financial level a little bit more difficult.
Right. Okay, so let's go on to our next scenario so we can get a little more flavor here. In this one, we do it best ASC in Connecticut is committed to performing only orthopedic procedures. The medical director, who also performs procedures at the ASC, schedules a routine orthopedic procedure on a 78-year-old woman in good health. But when the case presents in the OR, it is actually not an orthopedic procedure listed on the ASC's list of approved procedures or in the surgeon's clinical privilege list. The procedure is, however, similar to an orthopedic procedure and arguably within the skills and competency of the medical director. When the scrub nurse and anesthesiologist question the procedure, the medical director begins to curse at them because of the presumed impertinence of questioning him. The medical director is notorious for his vicious temper, and there have been a number of complaints regarding throwing of equipment and demeaning comments to all staff. Unfortunately, the administrator is out on a sick day, so the scrub nurse and anesthesiologist feel that they have no recourse but to allow the procedure to move forward. The procedure is successful, but the scrub nurse and anesthesiologist are outraged and write a letter to the governing board of the ASC. Dr. Brodsky, what do you think? Should this procedure have moved forward?
No, so I'm going to make a couple of comments here that that we've adopted at our ASC, not for issues that have happened to our ASC, but issues that we've been made aware of at other facilities, I'm going to say in New York State. So for this reason, or similar reasons, we have two medical directors. So staff should always, whether it's myself as a medical director or the other medical director, they should always feel that just being a medical director is not above recourse, can't do what he wants to do. So if a center has two medical directors, then you won't run into these situations as much, because if medical director one is acting out or doing the wrong thing, the staff has someone else to go to. The fact that the administrator on duty, whether it be the nursing administrator or the administrator of the ASC is out, there always has to be a clear chain of command, someone who's stepping in for them. This is something that every day we know at our ASC who's in charge from the nursing point of view. And it happens for practical reasons. You may have PTO that's 4 weeks or 5 weeks. Maternity leaves, the staff always has to know that there's someone to turn to. So the mistake here, as I see it, even started with, how is this procedure booked? And I've heard instances like this. So, at an endoscopy center, we have endoscopy, we have colonoscopy, we may have a few other procedures. But certainly if someone wants to book a procedure that is not being done, they can't even book that. So whoever booked the procedure, so there's multiple failures here. So I would start with who scheduled the procedure, how is it scheduled? If it's not on the list of approved procedures, even if the surgeon is privileged for that at, say, an area hospital, it can't be done at the facility. So it should not have been done.
Right.
I go so far as to say if this medical director has a vicious temper, it's probably not the right candidate to be medical director.
Good point. I agreed. So Len, do you think we should take a disciplinary action against this medical director? Even though there was
Yes,
no patient harm?
yes. Whether or not disciplinary action is taken should never be dependent upon whether or not patient harm occurred, because if that's the standard, then you're enabling, if not encouraging, conduct that is likely to, at some point, result in patient harm. And in this particular scenario, let's focus on the part where the director is notorious for vicious temper and complaints of throwing equipment and demeaning comments to all staff. This type of behavior is commonly referred to as disruptive conduct. And a few years ago, the Joint Commission specifically commented and issued guidelines on how disruptive conduct of this nature, and many other types as well, has a direct impact on the quality of patient care. And as a result of that, as well as the evolution of facilities, both hospitals and ASC's views as to what is tolerable by a practitioner in the OR, corrective action as a result of disruptive conduct has been much more common and accepted. And there's been a similar evolution in the courts, so that where practitioner who files a lawsuit because their privileges have been suspended, restricted, or revoked as a result of disruptive conduct, several decades ago, those types of cases, as compared to corrective actions based on clinical issues, were looked at somewhat askance by some courts. They weren't completely convinced. That's no longer the case. And there are legions of state court and federal court decisions recognizing that disruptive conduct of this nature by physicians has no place in the healthcare environment, as it does have a negative impact on the healthcare team's ability to provide high quality patient care.
Thank you. I think that's a super important point to keep in mind. We hear about disruptive physicians really affecting the quality of care a lot, and it's not something to be ignored.
And the morale of the staff. So it becomes not just a quality issue, but it's an HR issue. And I've seen that probably happen more than even the quality issues. The staff knows their rights, and the HR issue could really impact the center financially.
Yeah, that's also important. Very. Okay, we have the administrator at Improve Now ASC in Connecticut is informed that nurse kindness has been showing up consistently late for work. When interviewed, the nurse explains that she is going through a difficult divorce and is facing significant child care challenges. This is one of the most talented nurses, so the administrator lets it slide. Then nurse kindness gets into an altercation with a technician who questions her process for wasting unused narcotic. This is technically the anesthesiologist's responsibility, but nurse kindness is always willing to help the busy physician staff. The administrator reviews the narcotics logs, which seem consistent, and again shrugs off the incident. 2 weeks later, Ms. Jones shows up at the ASC asking for nurse kindness, who has been helping Ms. Jones obtain Dilaudid at a reasonable price. When questioned, nurse kindness denies any allegations. So, Dr. Brodsky, what should happen next?
Certainly need to, have your nursing staff, even your consultant pharmacist, really look at the narcotic documents to see if they're being done correctly. And a lot of times this is now computerized. Usually when you're taking out the narcotics, you have two people who are looking at the narcotics. We've had, really tweaked our process for both wasting narcotics and signing out narcotics to avoid these types of things. But certainly, the nurse herself should not be documenting the narcotics that are being taken out by herself.
And would you send this nurse to get drug tested?
Um, I would certainly consider it. I mean, it's always yes. So I would say yes. My simple question is yes.
Yeah, because it kind of seems like maybe she's selling, maybe she's using, maybe she's in a bad spot financially. And then, Len, what do you think about drug?
Since I'm sorry, Stacey, to interrupt. So since you brought that up, what is the center's I'm gonna say obligation or to send this nurse for drug testing, and what if the nurse refuses?
Well, there's no obligation under the law to send your employee for drug testing. And in this scenario, there doesn't seem to be any evidence that, well, there's not direct evidence that the nurse is using or
Right, so she's not
other
impaired.
than showing up consistently late for work. So that's a possibility. But I think the first thing to happen is that you conduct an investigation. The nurse should be placed on administrative leave during the investigation. And if it reasonably appears that narcotics diversion has occurred, you would be within your rights to terminate the nurse's employment. And such a conclusion would trigger reporting requirements under various state laws. In New York, it would be the Bureau of Narcotics Enforcement. Under New Jersey, I think it's the Department of Consumer Affairs. Is that right, Stacey?
And CDS, yep. Mhm.
Right. I'm not sure what it would be in Connecticut, if you know.
Not off the top of my head, I don't.
And would similarly, it would require reporting on a federal level to the Drug Enforcement Administration, the DEA. The either or both of the state or federal reports are likely to result in an investigation by their respective agencies and may lead to a site visit by a representative of those agencies who might question representatives of the facility or individuals involved who could provide information.
Right. I think in this one, an important aspect is the reporting obligation, both to the licensing agencies, which is who receives also reports of controlled substances in Connecticut, which is the Department of Public Health, the DEA, and if you're in another state, whatever their state narcotics board would be. Um, in this situation, just to note, once you report to entities that are monitoring controlled substances or looking at that, they almost certainly will come in to inspect and interview themselves as well. Both the feds and the state agencies take misuse of controlled substances extremely seriously. The DEA always doesn't come in itself, but it works with the state agencies in this type of investigation. Whereas reporting to licensing boards about misconduct doesn't usually result in site visits. But just so everyone's aware of what you will see, not to deter in any way the reporting obligations, these things are important, but just so you know what happens once the report is made.
Right. So in addition to the reporting to the narcotics agencies on the state and federal level, depending upon the results of the investigation, it is likely to trigger a report to the professional licensing entities, like in New York, the OPD.
Right, exactly. Okay, we have time for really quickly one more scenario. This is nothing really went wrong, but the QAPI committee at We Are Great ASC in New York notes that over the past year, physician easygoing has been having a gradual increase in the number of complications and near misses on his cases. None of the incidents alone rise to the level of a serious concern or had any permanent bad outcome. Physician easygoing is very popular with the other surgeons and staff, so no one wants to say anything. After one case in which the anesthesiologist intervened to prevent a potential medication error, once again, no patient harm, the medical director determines that something needs to be done and proposes potential corrective action to the governing board in accordance with the medical staff bylaws. So, Len,
So
what
this
do you
is,
think,
this is a
or
very,
Neil, whoever wants to go, what do you think the board should do?
very, it's a very broad scenario. Certainly, you can say it can be too much medications being given, polyps are taken out incorrectly. There's so many things that this could be, but anything like this gets reviewed first by the quality assurance committee. So you would pull perhaps 10 or 20 of the physician charts, and you would have we would have two medical directors review this, two independent physicians review this, look at what your standard of care is, both in the community and at the ASC. And then if there was truly a deviation, not just hearsay, you'd have to institute corrective action.
Do you ever go outside the ASC to have charts reviewed? Like,
I have personally reviewed charts from other ASCs. So
okay,
that's certainly something that's a good point to bring up, that it takes away, I'm going to say, some of the conflict that can happen. I mean, certainly, getting back to one of your initial comments about an owner, sometimes I would think to avoid some of the friction with owners being investigated, going out to another ASC, asking legal counsel if they can suggest a physician who can do a chart review would be a good idea. But certainly, whether it's done externally or internally, you'd want to pull 10 or 20 of the charts, have two people look at them from start to finish, and then uh, if there is an outlier, something that's going against what's commonly done at the ASC, uh, I would certainly propose corrective action.
okay.
And the corrective action could take a variety of different forms depending
Right.
upon the severity or not of the findings of the review, whether it's from an outside review or an internal review. And, it could be monitoring, additional, continuing medical education, up to including mandatory consultation or simply retrospective review of charts. But certainly some degree of counseling would be appropriate in this case. And if the intervention doesn't rise to the level of a actual restriction of privileges, which, by the way, mandatory preoperative consultation would rise to that level.
Yeah.
If it doesn't rise to that level, then it does not trigger reporting obligations.
Okay. You know, guys, I could go on and on asking you questions about this one alone, but I think we're a little bit out of time. Fortunately, we're going to be participating in the question and answer session. So if people have questions, we can elaborate a little bit more on some of these issues, like what if we don't do anything and the next time he really harms someone, or thoughts like that. And we did have one additional scenario. Feel free to review and contemplate on your own how you think you would respond. Really appreciate your participation today, and we look forward to seeing you at the answer and question session. Thank you.
Thanks, everybody.
Thank you.